to the first video tutorial by Synapse. Topic for today's tutorial is WBC disorders. Okay, let's begin. WBC disorders. So major component of the WBC disorders is made up of WBC malignancies. Okay, so let's talk about the malignancies. So it refers to the neoplastic proliferation of WBCs, right? Okay. Now, so to understand the concept and the logic behind the WBC malignancies, we will have to look at the development of the WBCs. So where do these WBCs originate from? They come from the marrow, right? The stem cells which give rise to the WBCs. So from marrow, we have two different lineages along which a WBC develops, correct? We have the myeloid series and the lymphoid series. Myeloid series will give rise to your granulocytes that include the neutrophils, eosinophils, basophils, that also involves the monocytes. Right? So these are the cells that originate from the myeloid series. From the lymphoid series, we have the B cells and the T cells. Okay? So let me just give you an overview of what exactly happens in the myeloid series, right? This is about the myeloid series. First, we have the myeloblast. So we know the term blast refers to immature cells which have the capacity for multiplication. Okay, so from myeloblast, we will have the promyelocyte. So it's pretty obvious when there is something called the promyelocyte, it gives rise to myelocyte. Okay. From myelocyte, we have the metamyelocyte. And then we have the band forms, ultimately giving rise to your mature neutrophils. Okay. So this is pretty important to understand the WBC malignancies. Okay. So, and one more important thing before we start the topic proper, we need to understand the nomenclature of malignancies. Okay, WBC malignancies. We have something called acute versus something called chronic. Okay, so what does acute refer to? Acute means, okay, the immature cells have increased. Okay, rather it is the malignancy and the proliferation of the immature cells. Chronic refers to the increase in the mature cells. Okay, right? So that is acute and chronic. The next concept is between what is leukemia and lymphoma. Okay, leukemia and lymphoma. So, leukemia means the malignant cells are in the marrow. Okay, and they can come into the blood. Okay, so what is lymphoma then? The lymphoma means the malignant cells are forming an aggregate, right? So these malignant cells, they're all stuck together and they form an aggregate and they are localized in a lymph node, okay, or your extranodal structure. Okay, so it could be nodal or extranodal. Okay, so that will become clearer as we go through the topic Right. So now let us start with what is called AML. AML. So now it's pretty simple, right? So what does A stand for? Acute. So what are we referring to? The immature cells, right? So the early cells. Then M stands for myeloid. We have just seen the myeloid series. So it is to do with the neutrophils, eosinophils, and the basophils. Then L stands for leukemia. As in these malignant cells are localized. Okay, so they are predominantly found in the bone marrow. Okay, so the name is pretty clear. So let's study about the AML now. So what is the mean age? Mean age for appearance of AML. They say it is 67 years. Okay, Robbins and other standard textbooks say 67 years, but in India it occurs at around like 50 or 54 years. So just remember 50 to 60 years. Okay, that is something you have to remember. And what is a sex predilection? Males more than females, right? So next, what are the risk factors that are causing AML? So first and the most important would be the environmental risk factors. So what are the environmental risk factors? First is smoking. Very, very, very extremely important. Smoking. Okay, smoking is a risk factor for development of AML. So you can imagine, right, a person who is 50, 60, male, who has smoked enough, okay, can have AML. He is at risk for developing AML. So apart from smoking, radiation, okay, radiation, then exposure to benzene, and last one is the drugs. Okay, we have alkylating agents. And one drug to be mentioned specifically is etoposide. So these are the important environmental risk factors. So what is not to be forgotten here? It is smoking, radiation, benzene, drugs like alkylating agents, and etoposide. Okay, next let's move on to the other risk factors. So first one are the environmental risk factors. Then we have certain hematological conditions, okay, that could predispose a person to develop AML. So in this, it could be acquired condition or it could be congenital. So acquired hematological conditions include myeloproliferative disorders, okay, then aplastic anemia, PNH, paroxysmal nocturnal hemoglobinuria, and here only I can include myelodysplastic syndrome as well. Okay, so I shall tell you what is MDS and MPS, because frankly you and I had the similar confusion before I kind of figured it out. So MPS and what is MDS? Okay, MPS, it is proliferation, right? So this stands for proliferation, proliferative disorder, okay, rather syndrome or D disorder, whatever. Okay, proliferative disorder. So it includes like 4 disorders, right? So first one is CML. Next one is polycythemia vera, essential thrombocytosis, and primary myeloproliferative myelofibrosis. Okay, how do you remember these? Okay, see, it is myeloproliferative disorder. So just now we studied what are the cells, okay, that are formed from the myeloid series, right? So we said the neutrophils, the eosinophils, the basophils, the monocytes. Actually, the RBCs also form from the myeloid series as well as your platelets. Now, if you see it that way, CML is basically disorder of WBCs, polycythemia vera actually RBCs. Okay, essential thrombocytosis is disorder of platelets, and myelofibrosis is because of the production of cytokines by the platelets. It produces or stimulates the fibroblasts in the marrow, hence results in myelofibrosis. So now it becomes simple, right? So there are three components, okay, and that are included in the MPD. Okay, so what is this dysplastic syndrome? Myelodysplastic syndrome. This D stands for dysplasia, right? So dysplasia means incorrect proliferation. Simple, right? So dysplasia means incorrect proliferation. So I shall give you the difference between MDS and AML in a while. Okay, so we'll come back to that. So I guess this is pretty much clear. The hematological conditions that form risk factors for development of AML, we have acquired and congenital. In acquired, MPD, MDS, aplastic anemia, and PNH. So inherited, some conditions that you should not forget would include the, okay, let's write it here only. We'll write it here, DNA repair, right? So impaired DNA repair. So what are those syndromes again? So again, we have a set of 4 syndromes. So those include ataxia telangiectasia, Bloom syndrome, xeroderma pigmentosum, and Fanconi's anemia. Right? So these are the 4 disorders which come under impaired DNA repair. Next, apart from this, okay, we have to include one more very important, that is Down syndrome. Okay, I'll just mention about Down syndrome in a while, but this is a very important association with AML. Okay, or it could also be congenital aplastic anemia, right? So there's so many causes of congenital aplastic anemia, if you could remember, but I would like to highlight one important cause, that would be pure red cell aplasia. Okay, that's congenital. That is called as, it's called Diamond Blackfan syndrome, right? So this is something we have read in physiology. Okay, Diamond Blackfan syndrome. So these are the important risk factors for the development of AML, right? So, okay, now let us move on to the next part. Okay, so once we know the risk factors, what should we know now? Okay, we'll talk about the important translocations. Okay, see what is happening in AML. I said it's acute, so your immature cells are increasing. Okay, one problem is that cells are not maturing. Okay, cells are not maturing, and 2, the blast count is increased, so there is increased proliferation of these immature cells, correct? So the cells are not maturing. So what is the reason for this? We have 3 important translocations that are associated with the arrest of differentiation rather. Okay, so if you ask me what is it that you should take away from this lecture, would be these 3 translocations. You cannot afford to forget this, right? So 821, 1517, and 1616. Okay, just take some time out. If you want, pause the video. Try to remember these numbers. Translocation 821, 1517, 1616. Now what about this 821, right? So I'll just mention that this is having the best prognosis. Okay, best prognosis. And so is 1616. This is also associated with best prognosis. Okay, and this is having intermediate prognosis. It is intermediate prognosis. Not so good and not so bad. Okay, so I remember it as like even numbers. So even numbers have good prognosis. Okay, and this has not so good prognosis. Okay, fine. Now let us look into the classification of AML. So we've been told, right, from our second year that we have the FAB classification. Starting from M0, we go to M7, right? M2, M3, M4, M5, M6, and M7. So what was M0? M0 is there is no differentiation at all. Okay, no differentiation. So M1 stands for it is myeloblastic, and there is no differentiation, no maturation rather. Okay, so there's a difference between differentiation and maturation. Okay, so myeloblastic, no maturation. M2 is also myeloblastic with maturation. M3 is promyelocytic. How do you think I'm kind of figuring this out, right? It's blastic, cytic. So it is the exact same order, okay, of the maturation of the myeloid series that was told in the beginning, right? Just remember that and the table becomes easy, okay? Promyelocytic, fine. Then we are having myelomonocytic, okay? Then M5 is monocytic. M6 is erythroblastic, and last one is megakaryocytic. Right? Okay. So M0 to M7. So there are like 2-3 points that you need to remember that I shall highlight in the same table. So M0 not that important. M1 again not that important. So which is the most common type? That is the M2 type. M2 is the most common type of AML. Okay, so most common type of AML is M2, right? Okay, so this is associated with what is called as myeloid sarcoma. Okay, myeloid sarcoma. And M2 is associated with one translocation which I just told, 821. Okay, associated with good prognosis, right? So M2 associated with 821 translocation and myeloid sarcoma. So myeloid sarcoma includes chloromas, sweet syndrome. Basically, it means the skin manifestation. Okay, so here you have cutaneous leukemia. Cutaneous leukemia as in skin involvement. Okay, and there is something called sweet syndrome. Similar thing, right? Again, skin involvement with erythematous skin lesions and chloroma. So what does chloroma refers to? Okay, it refers to the involvement of the orbit or the paranasal sinuses. Okay, those are called as chloromas. So I have mentioned that translocation 821 rather, sorry, is associated with good prognosis. But in the presence of chloromas, it will turn into bad prognosis. Fine, that is something to be remembered. Next, let's move on to M3 type. So M3 type is associated with translocation 15, 17. Again, how do you remember? 15 is a multiple of 3, right? So translocation 15, 17 and is associated with DIC. Again, 3 letters, right? DIC is associated with M3 type of AML. Next, let's talk about M4 and M5. So M4 is associated with translocation 16, 16, Well, again, 16 is a multiple of 4. It's easy to remember. And remember this, myelocyte. Again, this is, sorry, a monocyte, and this is also monocyte. So monocytes are nothing but your, basically, they turn into macrophages. So where these macrophages, they're in the tissue. So they have a predilection to go and enter the tissue, correct? So these two are characterized by gum hypertrophy. Gum hypertrophy. Right? Okay. So, but it is more with M5 type compared to M4, because see, this is purely monocytic. Okay, got it. Then, what is important regarding erythroblastic? Erythroblastic is just that it is drug related, or rather therapy related. So, what are the two drugs that was mentioned? Alkylating agents and etoposide. So, they are associated with M6 type of AML. And M7. So there's something important regarding M7, that is association with Down syndrome. This association with Down syndrome. So children with Down syndrome. Okay, here is the catch. Listen. Okay, see, children with Down syndrome, the most common leukemia would be ALL. Because children, so in children, the most common type of leukemia is ALL. But if they have AML, then it is going to be type M7. Okay, now let's say there's a normal child. This is a normal child with AML, and here you have a child with Downs with AML. It's somehow seen that Down's child with AML has a better prognosis compared to a normal child with AML. Okay, so that is something that you need to remember. Okay, so now this kind of classification, what we saw now, the FAB classification is not used anymore. So what do we use then? We have WHO classification. Okay, WHO classification. Why aren't we using the FAB classification? Because see, it doesn't give more information. So if it is M2 type or M3 type, it just tells me it's M2 or M3. I don't really know about the outcome, nor do I know anything about the prognosis, right? So WHO classification aims at giving the complete information regarding the disease. Okay, so what is the first type here? Here it's called AML with recurrent genetic abnormalities. Okay, so what does this include? You guys should be able to tell me quickly. That is translocation 821, translocation 1517, and translocation 1616. Okay, what kind of information do I get? These two are good. This one is having intermediate prognosis. Okay, simple. Right, so next we'll go to the second type. What does it say? AML associated with MDS. What did we say MDS was? Okay, fine, I'll give you the point here. See, for AML, when do you call it AML? When the blast count, okay, so the blast count is more than 20% of the marrow. Okay, if it is between 5 to 19%, it is called MDS. So basically MDS will eventually transform into AML, or you can say it is the prequel to the development of AML. So that is MDS. MDS can develop into AML if the blast count increases beyond 19%. Okay, so next one is AML with MDS. Simple. So first one was with recurrent genetic abnormalities. Second one is with MDS. Third, it's drug related. And fourth one is AML not otherwise specified. So not otherwise specified. Okay. Well, so now we know the classification and all of this. So let's move on to the clinical features. How does the patient present? So clinical features, it's very easy to make out now because we know the pathology. We know the immature cells are increasing, right? So where are the immature cells? In the marrow. So the immature cells in the marrow are increasing and they take over all the space that is there. Okay. So as a result, what happens to the other lineages? They will decrease. As a result, we will have pancytopenia. Okay, very important. We have pancytopenia. So that includes decreased RBCs, right? So we will have pallor, anemia, weakness, okay, and palpitation, and all these features. Okay, that is about decreased RBCs. Then we can have decreased platelets. So that will have bleeding manifestations in terms of bruising, epistaxis, and so on. And we will also have decreased WBCs. What I mean are the mature WBCs, right? So they can have minor infections. Minor infection. What's the catch here? Why am I not saying major infections? See, what happens here is though your mature cell count is less, but your absolute neutrophil count will be around more than 500 cells per microliters. So they will prevent the major infections. So they'll have some minor type of infections, okay. And the most important feature among this is this, okay, the decreased platelets, that is thrombocytopenia. That is how most of them will present. Fine. Now, okay, so this is what is happening in the marrow. This is the marrow picture. Okay, so AML is a disease of immature cells. So they are in the marrow. Are these immature cells coming out? No. Once they mature, only then they come into the circulation. So, do you expect lymphadenopathy here? No. Okay, it's rare. Do you expect hepatosplenomegaly? Again, rare. Okay, so it's basically your marrow findings. Okay, and proliferation in the marrow. So what is happening in the marrow? There is expansion, okay, because there is hypercellularity. So this can result in bone pains. Okay, so the patient can have bone pains. Fine. Okay, so this is how the patient has presented. But see, these findings are rare. So this is seen in less than 15% of patients. So if we are studying AML, keeping in mind M2 type of AML as the standard. Okay. When you come to the other types like M3, M4 and M5 where the mature cells will increase, right? So then you can have features of splenomegaly, hepatomegaly, but it is seen in less than 15% of patients, okay? And there's one more thing that I would want to highlight here, which will be useful for the further lectures. They are called as the B symptoms. What are B symptoms? They are the systemic symptoms like fever, weight loss, and night sweats. Okay, so these are the systemic features, right? So what are these due to? It's very simple. So we know all of this is because of cytokines. And who produce cytokines? WBCs. The catch is mature WBCs produce cytokines, right? So do you expect patient will with AML to have a lot of B symptoms? Obviously not, because we have immature cells, they're not the mature cells. CML, on the other hand, patient with CML will come with a lot of predominant B symptoms. Okay. Well, okay, now how do we investigate this patient? So there's a patient come with this AML. So you're suspecting it. So first we will do a blood study, right? So first we are going to study the morphology of the cells. Okay, so how do we do this? We have to study the morphology of the tumor cells in a peripheral smear or on a biopsy. You do a marrow biopsy and we are going to see the cells. So what you're going to see here? Okay, we are going to see the myeloblast, because we are keeping in mind the M2, that is the most common variety, correct? So M2 is characterized by myeloblast with maturation. So what do you see here? This is very important. Now, myeloblast versus lymphoblast comparison. So size of myeloblast is larger, and when you see here, this is obviously smaller, and the cytoplasm. So this cytoplasm here is very less. So see this portion. This is the cytoplasm here, very tiny. Here, if you see, there is, moderate amount of cytoplasm. It's more than what is in the lymphoblast. Then we see rods. These are the most important features just present in the myeloblast. And see, lymphoblasts do not have it. Okay, rods are present only in like your M2 and M3 variety. Okay, and M3 has more of rods compared to M2. Okay, so M3 variety has highest number of rods. And then nucleochromatin, so this is finer and this is much coarse, right? So you can see it's coarse, this is finer, and these are the nucleoli. So nucleoli are prominent in myeloblast. So these are the features, okay, how we identify a myeloblast. Okay, is that understood? So these features are extremely important. So that is how we are going to do. First, we are going to do the morphology study, right? Okay, fine. So next we are going to check what is called as your cytology. Okay, so we are going to go into the cytology. Fine. Remember the cytology part. See, what happens in cytology is we have found the myeloblast. Okay, now we need to confirm it, right? So sometimes from the slides it may not be obvious. Okay, so now we need to confirm. So what we do is we use some stains. What are the stains? So for myeloblast we are having two stains. We have MPO, everybody knows that, and we also have the Sudan black. So these are the two stains that we are using for myeloblast. On the other hand, for lymphoblast we will have the per-iodic acid skiff, PAS, and then we have acid phosphatase. These are the two stains that we'll be using for the lymphoblast. Okay. So next we have to look at what is called as immunophenotypy. So from this you will get to know whether it is belonging to the myeloid series or the lymphoid series by these two tests, that is morphology and cytology. Next, to be like 100% sure, we have to do what is called as immunophenotyping. That is immunophenotyping. Basically here we are going to study the cell markers, that is the CD markers, right? So this, okay, you have to remember, there's no other way out. So CD11B, CD13, CD33 and CD117. So these are the CD markers on a myeloblast. So again, CD11, CD13, CD33 and CD117. Okay, and there's one more that I had mentioned, that was the megakaryocytic type, that is M7 type of AML. So M7 type of AML will have M7 type will have CD41 and CD61. Just remember these two, right? So CD41, CD61. Okay. 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 So all of this has been told, right? So first we did morphology, then we did the cytology, right? What did we do in cytology? We studied the stains, okay? Then we will come to the immunophenotyping. So we check the CD markers once again, because the more number of times you tell it, you'll remember it better. So CD11B, CD13, CD33, CD117. These are the markers on the myeloblast. So then we can study the cytogenetics, right? Cytogenetics. That means your translocations. Quick again. Translocation 821, which is good. Translocation 1517, which is intermediate. Translocation 1616, which is good. Okay. All of this is understood. Okay, cool. Now we have diagnosed and everything is done. Okay, one important thing that I forgot to mention here is the one with the worst prognosis. We said good, and intermediate. This was intermediate. Now we'll talk about something called as the worst prognosis. That is inversion 3. Remember this, inversion 3 is having the worst prognosis. Okay. Now, let's go into the treatment part. Okay. Now, let us study the treatment. How do you treat AML? Okay. Now, before we start treating AML, there's one thing that has to be kept in mind. What is that? Tumor lysis syndrome. What is TLS? It is tumor lysis syndrome. So what really happens is that the turnover is high. Okay, you have a number of immature cells and they are not normal. So the clearance rate is high. So those cells are undergoing degradation at a rapid rate. So what happens? Increased uric acid production. Correct. So what happens when there is sudden increased amount of uric acid? It will go and clog your tubules in the kidney, causing uric acid nephropathy. Okay, this is happening because of disease process. Now, let's say I didn't check if the patient has elevated levels of uric acid or not, and I start him on chemotherapy. So what happens to the turnover rate? Further increased. Correct? So he will end up in a very bad condition, right? So he'll have renal failure and we'll have to probably start him on dialysis. So this is very embarrassing and that should be prevented. So what should we do? We should first rule out the possibility of TLS. How? You have to check the LDH levels. Okay, so what is LDH? Okay, sorry, LDH levels. Lactate dehydrogenase. Okay, so this enzyme, lactate dehydrogenase enzyme, is present inside your cell. Okay, every cell has LDH, right? So when the cell is lysed, the LDH will be released into the circulation. Correct? So when the LDH levels are high, that means the turnover rate is already high. So there is a chance or probability of the patient having TLS. So what will I do if the LDH levels are high? I have to do two things. One, start the patient on allopurinol, okay, which will reduce the uric acid production. And the most important thing is fluid therapy. So we should start the patient on aggressive fluid therapy so that it will wash away the excess uric acid. Right? Now, what happens is, and also you should have this one, monitoring of the electrolytes, because cell lysis, cell is rich in potassium. So when the cell is lysed, what happens? Increased potassium in the circulation. So it is causing hyperkalemia. It causes hyperkalemia. Correct? So that is also to be kept in mind. Now we'll talk about the treatment proper. Okay. I don't know why this is popping out every now and then. Okay, so treatment. So once we have ruled out, okay, there is no TLS, take care of that, and then we will start the patient on chemotherapy. So what is a regimen? This is very important. 7+3 regimen. Okay, 7+3 regime. So this is what we are going to use. Okay, we are going to use 7+3 regimen. So what does this stand for? 7 days of cytarabine. Okay, and 3 days of daunorubicin. Okay, cytarabine for 7 days and daunorubicin for 3 days. So total of 10 days. So this is for 10 days. Okay, now What is the side effect of using donorubicin? This will cause cardiomyopathy. Causes cardiomyopathy. And both will have dose-related bone marrow suppression. There will be bone marrow suppression. Now, what is the importance of this? Okay, I've started the patient on say this treatment. Okay, and within 3 weeks, okay, within 3 weeks, around 80% patients will respond. They will respond. Okay, now what is the importance of this side effect? Bone marrow suppression. Okay, first of all, the total count will reduce. The bone marrow is suppressed, the total count will reduce. And your absolute neutrophil counts will also reduce. I told you these patients will have minor infections and not major infections because of the maintained absolute neutrophil count. Now, because of bone marrow suppression, the neutrophil count will reduce. As a result, they will be prone for infection. So, they can actually have life threatening sepsis. Okay, so it's not just starting the patient on the treatment, it is also making sure that the patient is kept in isolation. Okay, and he does not have much exposure in taking care of the risk factors, right, for the development of sepsis. So all of this should be kept in mind while treating a patient with AML. So what is this phase called? 7+3 days. So this phase is called as your induction remission phase. Induction remission. So I told you most of them after 3 weeks they will respond. So what do you do after that? That phase is called post remission. Okay, so most of them will attain remission. So what do you do post remission? The definitive treatment would be a bone marrow transplant. Okay, to go for a bone marrow transplant, an allogenic bone marrow transplant. So this is not possible because you need a match. Okay, you need a proper this one HLA matching should be done, and it is pretty hard to find a donor unless you have a sibling or a twin, right? So then it is easy, but practically it's difficult. Or if you can't do this, you just go ahead with high dose cytarabine. Okay, then there's something called the maintenance phase. Okay, maintenance phase. So normally see the treatment has three phases. First, your induction remission. So you induce the treatment, you start the treatment and attain remission. Then you have post remission phase, and then you have the maintenance. So, but in AML there is no role of maintenance phase. So just stop here. Okay. Okay. So one last point regarding the treatment is, I'll tell you what. Okay, I'm so sorry, this thing is not moving. I don't know why. The AML type M3. So what was the M3 type? It was the promyelocytic type. Correct? Remember, M0, M1 is myeloblastic without maturation, M2 myeloblastic with maturation, M3 is promyelocytic. Correct? So this is associated with which translocation? I told you 15, 17, simple. Okay, now there is something called, this translocation is called PML RAR alpha. So this is the actual translocation. So what is happening? PML stands for promyelocytic leukemia. Okay, and this could also be written as RARA. RARA. What does it mean? Retinoic acid receptor alpha. Okay, because of the presence of this receptor, the treatment of this condition is a little different. So we can give drugs which act on this receptor. Those are two things. One is you can give ATRA, basically all trans retinoic acid. Okay, all trans retinoic acid, or you can give arsenic trioxide. Okay, so that is about the treatment of the M3 type. And out of atra and arsenic trioxide, this is like more effective. And what do these two drugs do? Okay, they help in differentiation, right? So I had mentioned that AML, the problem in AML are like two things. One is arrest of maturation, next one is increased proliferation. So these translocations are the ones which are responsible for arrest in maturation. So if I use these two drugs, they act on the receptor and they bring about maturation or differentiation. Okay, so they bring about differentiation. Okay, so now it's time to understand something which is called a differentiation syndrome. So what happens? Okay, there's a patient with AML type M3, and let's say we're starting on atra or arsenic trioxide. So all of a sudden, the differentiation will begin. So now from immature cells, we will start having increased number of mature cells. So the absolute count will increase, your total count will increase, and I told her mature cells are the ones which release cytokines. So all of a sudden, they will have fever. They can have edema. Okay, because of these cytokines, the vessels become leaky. The patient will develop edema, pleural effusion. Okay, so these all could be the manifestation of a syndrome, which is called as differentiation syndrome. Okay, this will usually develop within like 10 days of starting in atra or arsenic trioxide. Okay, so that's pretty much what is important and things like you must know about AML. In further videos, let's take up other tumors, okay, especially the blood malignancies. Let's talk about CML, ALL, and CLL later on. Okay.